Good evening, everyone. Good evening, our chairman and our ESCO members and everyone that has joined in. We are glad you are here this evening. Thank you, Dr. Ebere. Our speaker for tonight will be Dr. Ogugua Okonkwo. He's a consultant ophthalmic and vitreoretinal surgeon with the Eye Foundation Hospital. He's also an honorary professor of Academic Union, Oxford in the UK. As we know, most of us know him as a passionate teacher. He's an excellent surgeon, an erudite scholar. He is our faculty lead for the OCT OSM pre-conference courses, which has held in the past 4 years. It takes up to a day to finish the teachings. He loves and enjoys teaching, and I'm really highly privileged to moderate this session. So I just want to advise on your seatbelt, enjoy the cruise on retinal angiographies on angiographies in retinal diseases. So we'll look at FFA, we'll look at OCT, and then IG. For the presentation proper, it will take 45 minutes. Then we'll have 15 minutes to ask questions. So please, you can drop your questions on the chat box as the presentation progresses. You're welcome, our dear presenter, and welcome everybody to this meeting this evening. Thank you.
Thank you.
Thank you very much, Dr. Mata Mary, for your very kind introduction. Can I share my slide, please? I hope you can all hear me clearly.
Yes, we can.
Yes.
Okay. Thank you very much. So I've been given the task of discussing. I've been given the task of discussing angiography in retinal diseases, fundus fluorescein angiography, indocyanine green angiography, and the OCTA, which is something that I feel we all need to know a lot about because it's the future, it's the present and the future. And then without further ado, I'll move on with the presentation. And I'd like to say that I have no financial disclosures to make pertaining to this presentation. So the learning points we'll discuss on the principles of the conventional angiography, talking about the fluorescein and the indocyanine green angiographies. We'll look at the technique, indications, and interpretation of results. We'll look at the utility in clinical decision-making. And I would like very much, I wish when I teach on angiographies, it's usually interactive. So I have case presentations that I want us, that will stimulate us, that I would like us to, in our various corners, to think about and probably prefer answers. Then we'll switch on to OCT angiography, looking at the advantages and disadvantages over the conventional angiography, the utility of OCT angiography, and then also case presentations. So please permit me to use the word Octa for OCT angiography. So the basics of angiography, it's basically imaging blood flow through the vessels. We want to highlight the blood vessels, look at abnormalities of flow and abnormalities of vessel integrity. To do this, we often require dyes, the fluorescein dye, which is usually given intravenously, but can also be given orally. And we know that there are two commonly used dyes, the fluorescein dye and indocyanine green dye, but these are not the only ones. These help us to visualize the circulatory system. And for today's discourse, we'll be looking at the retina and the choroid, but we know that there are vessels, such as vessels on the iris, on the cornea, which also can undergo angiographic study. So a brief history on angiography. Harold and David, these were medical students, and they described in 1961 the process of fluorescein angiography, but it was published by Gass. It was Gass who popularized this 6 years after. Same thing in indocyanine green, at around the same time, was first described by Fox and Wood, and the first description in owl monkeys, being able to image owl monkeys, was in 1970, 10 years after the first description by Fox and Wood. It took another 20 years before ICG was used in humans. ICG was used, and in the macular photocoagulation study, those of us who remember in the 1990s when the MPS study was being done, it was used to precisely localize occult choroidal neovascular membranes. And this was important because those occult choroidal neovascular membranes were hidden under pigment epithelial detachments. And there was need to thoroughly highlight them, accurately highlight them, so that laser photocoagulation could be done to the choroidal neovascular membrane and surround the borders as well. So we see that ICG and fundus fluorescein angiography have been around for more than half a century. But it's not just until 2014, roughly 2 decades ago, that Octa was first clinically described and used in clinical studies. So Octa is just coming on board and has come on because of some of the disadvantages of the conventional angiography that I'll be talking about today. So what is fundus fluorescein angiography? It is fundus photography of the fluorescein dye through the retinal and choroidal vessels. It is rapid sequence photography. So you inject the dye and then you have to take the photographs every second. It's a dynamic test. So it's not just looking, and I often talk to my residents and say, you have to go there and see the transit. So you want to see the dye transiting through the blood vessels. You need high quality fundus cameras so they can get high resolution images. The high resolution images are so important to be able to study. So it's not just a test you hand over to the technician and say, oh, go and do it and I'll look at the results. You want to make sure that you take those photographs every second. It's rapid sequence, and I'll explain the reason why, and I'll demonstrate some cases. It provides information on the flow characteristics within the blood vessels, records fine details of RP layout, and gives a clear picture of retinal vessels and the surroundings as well. Now, indocyanine green is similar, does the same thing, is looking at dye transit, but this time the emphasis is on the choroidal vasculature. It's rapid sequence photography, so you have to take the photographs every second. The entrance of high quality fundus cameras and filters has really helped to promote indocyanine green. Indocyanine green angiography did not pick up as it should have because of the absence of these high quality cameras. But as soon as these high quality digital cameras and scanning laser ophthalmoscopy came on board, then there was a buying into indocyanine green. And I'll also explain why. Now, this is looking at fundus fluorescein angiography. It's a sodium dye. It's relatively safe, an organic dye. It's brown or orange red crystalline, as you can see there. 80% bound to plasma protein. Therefore, 20% is unbound. It's alkaline. So it tends to get stimulated by shorter wavelengths in the blue spectrum, about 490 nanometers, and it emits in about 530 nanometers. So blue light goes in, and then you see yellow-green light coming out, okay? It is metabolized by the liver and excreted by the kidney. Indocyanine green, on the other hand, has a longer wavelength for stimulating, 790, as opposed to 490 for fluorescein angiography. And this is very important. And it tends to emit in the range of 835. Indocyanine green, therefore, has longer wavelengths. Therefore, it's able to penetrate through the retinal pigment epithelium. The retinal pigment epithelium restricts the wavelength, the emitted rays from the fluorescein. So the fluorescein dye that's in the choroid, or that is deeper to the retinal pigment epithelium, gets obstructed because the retinal pigment epithelium also emits and absorbs in that same wavelength. So light coming from the retinal pigment, under the retinal pigment epithelium, under hemorrhage, under xanthophyll pigments, and media opacities get blocked by when it is fluorescein angiography. But because indocyanine green angiography has a longer wavelength, as much as 790, the stimulation, and then when it emits about 835 to 850. It's able to penetrate through the RPE. It's able to penetrate through blood, through xanthophyll, through melanin, and therefore you're able to see the image coming all the way from the choroid. The other advantage that ICG has over fundus fluorescein angiography, FFA, is that whereas FFA fluorescein dye is bound by about 80%, bound to 80% of the proteins, 80% of it is bound to the proteins, the soluble proteins. Almost all of the ICG gets bound, about 98%. So you have only 2% that can leak out of the vessels, out of the choroid. Fluorescein has almost 20% that leaks out. So when fluorescein leaks out, it blurs the margin, it blurs the area. So you are not able to identify the margins of the lesions that are beneath the RPE in the choroidal space. And so this is a disadvantage because of this blurring effect that fluorescein will have, because it leaks very readily. You have 20% that's unbound, so it easily leaks out of the choroidal fenestrations. What kind of equipment do we need? We need photographic equipment. We need a light source for fluorescein angiography, filters blue that illuminate, and then the yellow-green barrier filters. So the barrier filters only allow light in the 530 green-yellow wavelength to emit out of the eye. The digital camera, 30 degrees. Typically, the digital cameras we have in our clinics are about 30 degrees, and then some of them extending up to 50 degrees. But these days, we have the wide field and the ultra wide field. So there's been discussion about what wide field really represents. Wide field is thought to be a single capture, where you can have a single capture centered on the fovea. And this is important, which goes and is posterior to the vortex frame. This is called the wide field. And then becomes ultra wide field when it goes beyond the vortex phase. Single capture, and I will show you images of this. Single capture that goes beyond the vortex phase, centered on the fovea. Now, we must bear in mind that only tissues that contain the dye fluorescence, and those are the ones that are visualized when we do fluorescein angiography. Equipment for ICG is similar. You need the camera that will excite, and then you need the barrier filters that will allow just the wavelength that you want to emit. And like I said, the SLO cameras have given us high resolution images. And that's because the SLO excites with laser light. It has laser monochromatic light that excites with the diode laser of about 790. So its laser light is very specific. And then the barriers 830, as I mentioned. We can perform dynamic ICG because we have the SLO system. The SLO system is better than the digital system, which uses flashing light. And this excites with white light in the range of 640 to 778. And the barrier filter is similar, but similar 820 to 900. It's wider than in the case of the SLO. So we must remember that as a standard of care, we must have an emergency kit. So when talking about equipment, we've talked about the camera, the excitation, the barrier filters. You must have excitation kit ready in case there's any anaphylaxis or sudden things that may happen. Remember this, and I know that when accreditation is being done, and we take, you go around to visit, the accreditation team is going around to visit, they usually will ask for the emergency kit, because though it is rare, but you might have those patients who could have fatal reactions, and you must be prepared to take care of them. So how is this procedure done? So the patient is seated comfortably, and you need to take an informed consent. You need to discuss with the patient, let the patient know that he may have some discomfort. Some patients feel very uncomfortable with I remember the case where we were very ready to do the test, and the dye had actually been withdrawn, and we were ready. The lines have been set up on the patient, discussion with the patient, and then looking at the patient, and the patient began to talk about allergy and all that, and we decided to abort the test, seeing the way the patient was reacting. So you need to look at your patient and understand that your patient is critical. You don't want to have a reaction that is unexpected. Remember to tell the patient that he or she will feel nauseated and there may be vomiting. So you want a patient's eye to be dilated. And some of the things you should keep your emergency kit, as I've explained, but you should also have a receptacle in case the patient wants to throw up. Now, you tell the patient that it is normal to feel nauseated. And it is normal also to maybe feel like vomiting, especially if the patient has eaten. So it's preferred if the patient does this test on an empty stomach, okay? So maybe early in the morning, or if the patient has recently eaten, it may not be a good idea to run this test and have a receptacle. Let the patient be aware that if he or she has to retch, she has to do that quickly and then get back on the camera. Otherwise, you're going to lose vital information. If the patient is feeling ill at that time and then stays away, then the reason for the test you lose it because you've lost the dye transit that you wanted to image. You want to take a rapid sequence. You want to take the image. You want to take the photographs every second. Usually, a 21 or 23 gauge needle is used. So you set up your cannula. You draw back. You have to make sure that you are right inside the vein. Okay, so you don't want to be outside. Because you don't want extravasation of the dye. Extravasation of the dye into the tissues can cause necrosis in severe cases, but it can be very painful and irritating. Okay, so make sure you withdraw, either you withdraw blood or you flush with saline to make sure you're in a good vein and that the vein, the cannula or the needle has not moved out of the vein. Typically, we give fundus fluorescein angiography. In our department, we use intravenously 5 cc if it's 10%, dye, then we give 5 cc. But in so many cases, we have 20 or usually 20 or 25%, and we just give 3 cc. In some cases, we have had situations where we give less. And I would inform that this usually depends on the degree of lens opacities. For instance, in the younger patients, those patients who are sickle cell, who have to have angiography, their lens is usually clear. They don't have any hemorrhage, and you just want to image the C-fans. These patients have very clear, visibility is very good, and you can give less dye. You can give less dye to them. And we discovered by chance, and this was a chance discovery. Once upon a time, we didn't have enough dyes, and so we had to share the dyes. And we discovered that when we share the bottles of dye, the incidence of nausea and vomiting went down drastically. So we do still share in some cases when we don't have enough, but very often we have more than enough. And so if you don't want your patients to have so much nausea and vomiting, I recommend that you can do a half dose of the dye. In fact, in some of the younger ones, you can give less than 3 cc. You can give 1.5, or even 2 cc to them. Okay, in ICG, we normally give intravenous 25 milligrams in 5 mils of solvent. We need to flush rapidly. Remember that this is a test where you want the bolus of the dye to get into the ciliary vessels and get into the choroid and into the retina very quickly. Right, so indications, what are the indications? For fundus fluorescein angiography, mainly those retinovascular diseases, diabetic retinopathy, diabetic macular edema, and diabetic macular ischemia. Retinal vein occlusion, we remember that the central vein occlusion study defined ischemic CRVO as 10 disc areas of non-perfusion on fundus fluorescein angiography. But these were before the days of ultra-wide field fundus photography. So there's a lot of discussion around this, and it's felt that 10 disc areas really does not, is much less for you to say it's ischemic. So things like choroidal neovascular membranes, in AMD, myopia, angioid streaks, in serpiginous choroiditis, presumed ocular histoplasmosis. This also will be an indication to image. Central serous chororetinopathy, ocular ischemic syndrome, where you have severe ischemia. Patients have carotid disease, retinal vasculitis. These are some of the indications. They are not limited to only this. And in ICG, it's mainly the posterior, the choroid. That's what you're interested in. The choroidal lesions, choroidal neovascular, the vascular membrane, especially the type 1. The type 1 choroidal neovascular membranes hide under the retinal pigment epithelium. At times, you see them under hemorrhage or underneath pigment epithelial detachment. So ICG is very helpful because, as I've said, the ICG, longer wavelength, is able to penetrate through the RP, through the hemorrhage, and through all that things that, all through the things that hide the choroidal neovascular membrane. Type 3 membranes, as we know, the RAP lesions, polypoidal choroidal vasculopathy, central serous choroidopathy, choroidal tumors, RAM lesions, white dot syndrome, inflammatory conditions. So how do we improve the image quality? The technique is very important. Your patient must be, you must discuss with your patients. Make sure the patient is well dilated. Assess the degree of cataract. In some cases, the patients may have had surgery, cataract surgery, like the diabetic retinopathy patients who have had cataract surgery, and they may have a PCO. So you don't expect to see a lot in those kind of eyes. That might be a situation where you don't want to go ahead. Maybe you want to do a YAG laser before you move ahead with doing your imaging of the vessels. You need to get the patient's cooperation. So discuss with the patient, inform the patient. If you feel nauseated, yes, you may feel a bit ill, but you must get back on the camera so that we can continue with the test. You want to do this. This is rapid sequence, so the rapidity is important. Clean your lens. The technicians who we are allowed to do this test for us, they may not be that detailed. So you must supervise yourself or the resident or the fellow. Now, because often they move the camera to and fro, at times they make the lens of the camera to touch the nose of the patient, especially those patients who have longer nose or something, they touch the skin of the patient so they can take up some grease. Make sure that this is well taken care of, well serviced. Now, before you inject the dye, what do? You want to take some fundus photography. You want to take some images of the disc, take some images of the macula, and images of the mid-peripheral and the peripheral retina. You want to test the quality of the excitation on the barrier filter. Evaluate for fluorescent structures within the eye, such as we see some of the features you see within the eye may have maybe autofluorescence, like we see the optic disc drusen that is shown on the picture by your right. The concept of pseudofluorescence is seen when you have old filters, old excitation and barrier, especially barrier filters that allow light that shouldn't come out to come out. So you may see pseudofluorescence. Remember, autofluorescence you see when there's self-illumination, the blue light goes in, stimulates the structure, and then it fluoresces. Okay, this is different from pseudofluorescence, which can happen even from exudates, from hemorrhages. You can see pseudofluorescence. Okay, so take photos. Remember that you have to take photographs of the fellow eye. Now, the normal dye transit takes about 10 to 15 seconds for the dye to arrive to the ciliary artery and get into the choroid. So the choroidal filling is first, then followed by the retinal filling. There's a 1 second interval between when the choroid starts filling. The choroid fills in lobules, okay, because of the arrangement of the choroid. So it fills in lobules. And it takes a total of about 10 to 20 seconds for the dye to transit through the retinal, arterial, and the vascular system. Then you continue taking seconds. And then you need to remember that even when you've done taking the seconds and you've seen the various phases, starting from the pre-arterial to the arterial to the arteriovenous, the venous divided into the early and the late phases, and then the recirculation. So here we see the images. This is the pre-arterial. Just a second. I want to put on the pointer. So this is the laser pointer on. So this is the pre-arterial phase, in which the dye has moved into the choroid, okay? And then it takes 1 second. In less than just about a second, it's getting into the artery in the B slide. And then it goes into the arteriovenous stage. Yeah, this is the early, during the early venous phase, there's lamellar flow. Then you have the venous phase. So you have the early and the late venous phases. And then you have the recirculation phase. Recirculation phase, the dye has gone out all the way out, and then dye is coming back into the eye. And then it allows you to see certain stages, which I will also discuss. In ICG, it's divided into early phase, the middle phase, and the late phases. And this also is time. The early phase begins 2 seconds after the injection of the dye. There's rapid filling of the choroidal arteries and the choriocapillaries, and then early filling of the choroidal veins. Stage 2, 3 to 5 seconds after the ICG injection, and then stage 3, 3 seconds. Then the mid phase stands 3 to 15 seconds and is characterized by fading of the retinal and choroidal vessels. The late phases will take up to 15 to 16 minutes, and there is staining of the extrachoroidal tissue. Now, how do you report? And this is really important. How do you report what you see? You report as either a hyperfluorescence or hypofluorescence. The image you see could be hyperfluorescence as a result of transmission increase. When there are missing cells, the RPE, remember that I mentioned earlier that you're also assessing not the vasculature, but the layout and integrity of the RPE. When there are missing cells in the RPE, you will see hyperfluorescence. Remember this. When there's leakage, either due to pooling or staining, or from abnormal vessels, this will also give you hyperfluorescence. It's hypofluorescence when there's a transmission decrease. Maybe the blood is not getting to somewhere, so you're not seeing fluorescing where you should be. So in that case, you will have problems with defects. There are defects. And in some cases, it might be because there's a coverage. There's something covering the fluorescence that you should see. So those two will give you hypofluorescence. So it's either there's something covering, it could be blood, It could be pigments or any other thing covering, or it could be because the blood is not getting to where it should get. These two features will give you a hypofluorescence. So I want us to go through, with that quick introduction, I want us to go through some cases on fluorescein angiography. Now, wherever you are, I want you to think about these cases. I'll give you time so that you can think about them. But because this is virtual, I cannot ask questions. But assuming those are a classroom environment, or then we will be able to ask questions. But I'll provide most of the answers. Now, so this is an image, you see. So the first thing we want to say to yourself is, what phase of angiography is this? What phase of angiography is this? So if you look carefully, you see that there's filling of the arteries and there is filling of the veins. So this arteriovenous phase, okay? Then you say to yourself, what is hyper or hypofluorescence? And you can see that indeed this area, the normal choroidal flush that you should expect to see here, is not really as it is in the other areas. And you see that the vessels that you should see, both the arteries and the veins, arteries and veins are hypofluorescent. So the dye is not flowing through. Okay, because the dye is not flowing through, you will begin to imagine that this might be a filling defect. Okay, and then there's something that is hyperfluorescent. There is something that is hyperfluorescent here. And that thing that is hyperfluorescent is an embolus. So we have an embolus. And so this is a central retinal artery, superior branch retinal artery occlusion with an embolus. So this is the embolus, and the embolus could be either of three things. It could be calcific, it could be fibrinoplatelet, or it could be cholesterol laden, the Hollenhurst. So this strikes me to be more of the calcific, and the calcific is the more dangerous type. It doesn't tend to move on. The fibrinoplatelet, we can embolize, we can thrombolyze, we can do thrombolysis to the fibrinoplatelet emboli and can reestablish flow. In many of the emboli, though they block, but over time they tend to move away so that flow is reestablished. So this is in the right eye with superior branch retinal artery occlusion, and we can see the embolus that has caused that. So this is another photograph, and we've seen the fundus photograph. So before you interpret a fluorescein angiography, ideally you should see the fundus photograph. So the fundus photograph, as we said, you should take fundus photographs before you inject the dye. Take fundus photographs of the eye that is essential, and then of the other eye. So tell the patient, I'll be taking photographs of your both eyes. You have to dilate both eyes. You concentrate more on the eye that has the lesion, and if the lesion is in both, the patient has to be stable. Someone has to hold his head so that you have to swing the camera between one eye and the other eye. So what frame is this? Now you can see that there is filling of these vessels. The choroid is filled. You can see the loss from the choroid. And we can see that there is fluorescence seen within the vessels that supply from around the area of the disc to the macula. And these are cilioretinal arteries. Okay, so the cilioretinal arteries show the normal fluorescence. There is really no hyperfluorescence, but what we notice is that there's generalized hypofluorescence of the vessels. So this patient has got a central retinal artery occlusion. Vision will be good because of the cilioretinal artery, but then he was going to have very considerable visual field defects. So again, what is the clinical presentation here? This patient has got a cherry red spot. And what causes this? This is a very young man who I happen to know, and he went out for exercise. And after explaining a round of football, he came back home, took his shower, and then he noticed that he could no longer see. And he was just in his 20s. And then when he came in, his vision was very poor. He was counting fingers, drastic reduction in his vision. He has a cherry red spot. And what could be the reason for this? This may be because of dehydration. He's just been outdoor in the sun playing football. So at times dehydration can actually give you a central retinal artery occlusion. That's a cherry spot this gentleman has. And he did not regain his vision back, but eventually he had some form of therapy and regained some vision. This again is another patient of mine. So we can see fluorescein angiography being done here. And in these two cases, there's a contrast. In one case, central retinal artery occlusion with cilioretinal rescue. So this patient's vision will not be as bad as in the case of this patient, who is also a patient of mine. Here you can see there is significant ischemia, non-perfusion. The FAS is not there. The FAS is enlarged. And so perfusion to the macular area is reduced considerably in the patient on the right. Whereas the patient on the left, there is generalized hypoperfusion. Okay, and we can see there's hypofluorescence in both when you see hypofluorescence in both the arteries and the veins, you know that this is an arterial occlusion. And there are characteristic features you see on OCT, which will show thinning in the inner retina. When you see thinning in the inner retina and the outer retina seems to be okay, then you begin to suspect central retinal or branch retinal artery occlusion. Okay, so this is moving on. This is a patient who came in with hemorrhages, slight reduction in his vision, not so much. And we can see fluorescein angiography showing areas that are hypofluorescent. So this fluorescence is due to hypofluorescence is due to blockage of the fluorescein. So there's blockage of the fluorescein. We can see that in this superior area, there's some degree of tortuosity in the vessels. So this patient has got a superior branch retinal vein occlusion. Now, I wonder if you can guess what this patient really has. But believe it or not, this is not central retinal vein occlusion. This is hypertensive retinopathy. This is hypertensive retinopathy. And you can see, make out here that this patient, even clinically, is beginning to have the star-like appearance, which you see of hard exudates, and that star-like kind of appearance. You can see significant tortuosity of his vessels. And you can see the same here. He has some few areas of hypofluorescence due to hemorrhage. You can see that here. This is hemorrhage here, and you can see the blood fluorescence. But by and large, a lot of tortuosity in his vessels. There's not much of cotton wool spots. So this is not a vein occlusion. This is hypertensive retinopathy, because you can see the vessels are large and large. You can see that there is flow, there's good flow through them. And this is a patient that you need to check his renal status and find out if he's young, find out why he's having the hypertension. So what are the predisposing factors for this? Mostly hypertension. So what does this picture show? This picture shows hypofluorescence, wide area of hypofluorescence that transverses the midline. So this goes across. And you can see some areas where there seems to be joining. There seems to be typically you don't see vessels cutting across the midline. So this most likely has been there for some time, because we are seeing bridging of vessels across the raphe here. We see that these vessels are connected, they are tortuous. So this is a patient who is having some form of decompensation after having suffered a vascular accident. You can see areas of hypoperfusion. We can see that the FAS in this area is not looking regular, it's irregular, and there's usually the FAS is it shows hypofluorescence, but this degree of hypofluorescence is large, okay? And we see areas of hyperfluorescence. The hyperfluorescence is due to two things. It's due to leakage and then to staining of the blood vessels. So the vessel wall here has gone some degree of trauma. There's trauma, there's ischemic trauma. Remember that the vessels are within ischemic retina. There's edema within the retina. So they tend to, edema within the retina tends to increase the interstitial tissue pressure. The interstitial tissue pressure within which the vessels are lying increases, and therefore it further narrows and reduces the lumen of the vessels. So the vessels that flow within those areas of ischemia, areas of hard exudates, area of leakage, undergo more shutdown. So, and that's the reason why when there's initial insult, if the patient goes untreated, there's a significant leakage into the tissues. The edema within the tissues impinges on the vessels, closes them down, and so you have worsening of ischemia over time. So you might see a patient who is not ischemic, and then you see the same patient months after he has become ischemic. He's had an ischemic vein occlusion. So this patient has a hemiretinal vein occlusion, and that's what he has. Now, this is classic. This you will see as, you see this kind of starry kind of appearance of hyperfluorescence. There's hyperfluorescence, a lot of hyperfluorescence, dots of hyperfluorescence all over. And then you see some areas of hypofluorescence, like we can see here. These most likely are areas, this would be an area where there's a hemorrhage, whereas this would be an area where there's capillary dropouts, where there's no perfusion. So those some areas are hypo because the blood is not flowing into those areas, whereas some other areas are because of blockage, like I explained in the beginning. And then you see areas of hyperfluorescence, which are areas where the dye is collecting, is pooling within the microaneurysm, and then it leaks over time. So you have to differentiate it. This is diabetic macular edema. So you have diabetic macular edema because you have hyperfluorescence around the area of the fovea. You have the leaking aneurysms there that gives you this kind of feature. You see the hyperfluorescence around there. And then this is non-proliferative because we do not yet see proliferative tissue growing on the retina. So this is non-proliferative diabetic retinopathy with diabetic macular edema. Now, this is diabetic retinopathy, and you can see all the classical features that we need to see. We can see the beading there. We see the IMERs, intraretinal microvascular anomalies. Typically, intraretinal microvascular anomalies do not leak on fluorescein angiography. That's one of the ways in which you differentiate them from new vessels. And we, apart from the beading, you can see here that there's AV nipping, that's arteriovenous nipping. So this is a tortuous vein, and then you can see that the artery here, which has undergone arteriosclerosis. This patient may have both diabetic retinopathy and hypertensive retinopathy as well. And in the frame on the lower part, you see hyperfluorescence, and you see even hyperfluorescence around the disc. So this patient has got new vessels on the disc, new vessels elsewhere, macular ischemia, lots of dots, microaneurysm. This is a patient who is at high risk. Now, these are two conditions that we need to always differentiate one from the other. And we said describe the similarities between the FFEs. The similarities are there's widespread hyperfluorescence. And the widespread hyperfluorescence is because of edema. So you have edema. These are two conditions where there's edema, but they're different, okay? And the prognosis is different. Now, in one case, it's usually acute in onset, whereas in the other, it is a chronic disease. And you can always differentiate them because in one, you're going to see what I described earlier, which is a dot-like hyperfluorescent spots. I'm saying this because of the residence. And you will see that in this eye, there is hyperfluorescence centered around the fovea. So hyperfluorescence, there's edema. Now, this edema is the type you don't want to see. This is due to a generalized breakdown of the blood-ocular barrier. So this is diffuse macular edema, diabetic macular edema, diffuse. So this suggests that there's one, when you see it as diffuse as looking at this, as in this eye, this is usually due to a widespread breakdown in the blood-retinal barrier, period. So this is diabetic macular edema, non-proliferative diabetic macular edema with leakage around the fovea. Okay, so this is the type of situation we in those days used to do grid laser for, but grid laser is terrible. Grid laser is no longer being done. This is a patient that will benefit from anti-VEGF now. This day and era. Of course, you need to do the OCT. Dr. Chineze Agweye 2 weeks ago talked so much about the OCT, so I'll try my best not to discuss OCTs here. We'll focus on just the angiographies. So leakage, widespread leakage, generalized breakdown in blood ocular barrier. You can see an area of hypofluorescence, most likely hemorrhage, dot hemorrhage. There's areas of this, it may be an area of flame-shaped hemorrhage. So there are areas of hypofluorescence that you can make out. But this is diabetic macular edema, usually in non-proliferative diabetic retinopathy. Whereas in the other case, you can see the Henle's layer rather. You can see that kind of starry nerve fiber area, kind of hemorrhage, distribution of hemorrhage, which you tend to see in macular edema, the Ivan gas that you can see after cataract surgery and after other types of surgery, but mostly after cataract surgery. So this is acute in onset. This is Ivan gas. The patient on your left will not do so well because this is a chronic disease. This is due to poor control of his blood sugar. This is due to hypertension. But in this other case, this is usually due to inflammatory mechanisms and steroids will be required. So you need to differentiate the two. Now, this is a patient who has a RAM lesion, retinal artery macroaneurysm. And so he's had hemorrhage, and you can perceive that the hemorrhage, fluorescein angiography has been done, you can perceive that the hemorrhage is under the retina, is subretinal, because you can see the blood vessels going above it. Okay, so there's a component of it that is pre-retinal, which is this component that you're seeing here, and then there's a component that is underneath. And the lesion here can be so well seen with fluorescein angiography. And what you can do to this is to apply gradual retinal laser photocoagulation to the lesion. But in the case that this lesion is already affected the fovea. And so this patient's vision would have gone so much down, you may need to do some other form of surgical intervention, either injecting tissue plasminogen activators to dissolve the clot and then can be displaced by air or any other thing that is used. So this is RAM, a RAM lesion retinal artery microaneurysm. This is a patient of mine who has very rare condition, and this is Leber's miliary aneurysm. You can see this is a lady, a young lady. She didn't even know the right eye had only gone, and this was the left eye, significant exudates. And we can see the huge bulbous circular dilatations. And this has undergone cicatrization, this particular one, whereas in the other ones, you can see on fluorescein angiography, see this patient usually have ischemia also in the periphery. So you need to treat not just the bulbar aneurysm now dilatation, but you also need to treat the ischemia. Okay. Now this is a condition that everyone knows because it's peculiar to us. This is a patient who has an ultra wide field fluorescein angiography. Now in this case, you can see that he has C fans leaking in the extreme periphery. So this is a C fan neovascularization of which you see in patients who has proliferative sickle cell retinopathy. This lesion is not bleeding. So this is one of the things I had mentioned, that in this kind of patients, you get excellent angiograms once there's no bleeding, because the cornea is clear, the lens is clear, you see a lot. Okay, so and you can see on the slide on your left, you can make out the areas of non-perfusion. So this is in stage 2, and then moves to stage 3, flat new vessels, and then by the time they start bleeding, this go back stage 4. When they pull further and they have a traction retinal detachment, it is stage 5. Let's move on quickly to macular lesions. So this is a patient who has drusins. So drusins can appear as hyperfluorescent spots in the macula. We expect that the fovea should be hypofluorescent. But in this case, they are hyperfluorescent because the collagenous tissue, the material, the waste within the lipofuscin and all the waste elements, the cholesterol material within the drusen, they stain with fluorescein. So you can see that on the staining pattern here. You also want to look out to see whether there is neovascularization. And this is another eye. This patient tends to have more of geographic atrophy. We see the drusen, this kind of discrete light drusen that this patient has got. No new vessels that we can see, no hemorrhage. There are hyperpigmented areas which suggest problems with the RPE. And then when you look at the slide, the angiography on your right eye, we can see window defects. This is due as a result of dropout of the RPE cells, and so we are seeing the choroid beneath this. So this is a window defect. This window defect, hyperfluorescent with well-described distinct borders, window defect. And on OCT, we can see the undulations that we see in the outer retina, this drusen. And when the drusens coalesce, they form bigger drusen. And so we can see a coalescence of the soft light drusen. They can give you pigment epithelial detachments, these well-defined borders, hyperfluorescent areas. These are due to coalescence of the drusen, giving you soft drusen. So you can have the soft line of drusen, you can have the hard drusen, you can have a mixed presentation, you can have the cuticular kind of drusen. And the image on the right shows us a choroidal neovascular membrane. So this is a type 2 choroidal neovascular membrane. As we see, well-defined borders, lacy pattern of hyperfluorescence. Usually type 2 will be beneath the neurosensory retina. That is within the RPE, between the RPE and the neurosensory retina. So it's in the subretinal space. Usually fluorescein angiography will be required, and it's very good at depicting this. So you can see the well-defined borders. So this has a subfoveal component and also the extrafoveal component, a fairly large choroidal neovascular membrane that we have. And choroidal neovascular membranes, as I've said, can be occult. And in this case, some of these cases, like I mentioned, alluded to earlier, you can use ICG. ICG can be very helpful in seeing the occult membranes that lie beneath the RPE. This is a very important tool for ICG. Now, this is a patient of mine who we happen to manage very recently, and she has a montaged wide field fundus photograph. And she's received significant number of injections. We recently started her on faricimab, and we expected her to do well, but her vision will wane and wax. Okay, I'm sorry. I think that patient will be coming back later. That was a slide that wasn't supposed to have been there, but I'll discuss that patient later on. So still looking at the macular lesions, we can see that the choroidal neovascular membrane can still be used, can still be seen in this presentation. So in some cases, you may need to do what we call multimodal imaging. So here we have the fundus photograph, the same eye, the fundus autofluorescence, the fluorescein angiography, indocyanin green, all showing us different aspects of the same lesion. But here we'll see the choroidal neovascular membrane. And that is so vital to be able to delineate the choroidal neovascular membrane. Delineating the choroidal vascular membrane helps you to be very specific with your treatment. Okay, so you're able to map out your treatment if you have all these methods of imaging. And imaging has become so vital. You can hardly go for any meeting without a session on imaging. So this is the same lesion being imaged by different techniques. Fundus autofluorescence helps you. There are different types of the fundus autofluorescence. So you can have the blue and you can have the blue, the green, and the infrared. The infrared helps you more with things in the choroid. The green, which is longer than the blue helps to image things in the inner retina. The mid retina towards the neurosensory retina, outer retina will be imaged with the green. So here you can see this really is blue. This is imaging blue. And this is fundus autofluorescence. This is fundus fluorescein angiography. This is indocyanin green. And there you can see the choroid. You can see choroidal vessels. Once you can see the choroidal vessels, you know this is ICG. Okay? So still looking at lesions where we can do multimodal imaging. And here you have a patient who has got polypoidal choroidal vasculopathy. And you can see that here there's to be able to see the polyps, usually they have a hypofluorescent halo. And this is one such lesion. There's a hypofluorescent halo around the area of hyperfluorescence. So hypofluorescent halo around the area of hyperfluorescence, that is the polyp for you. The polyp can be imaged through, this is just trying to show us that despite the fact that you have hemorrhage, you have this wide area of hemorrhage, fluorescein angiography will not be able to do this. But you can establish the presence of the polyp using indocyanin green. And you can also do OCT with these lesions, looking at the polyp, the same polyp, and you'll be able to see this multi-peaked pigment epithelial detachment that seem as if they are, when you see them, as if they are projecting out from the choroid. With that alone, you can diagnose polypoidal choroidal vasculopathy, and you can diagnose the polyp. So in polypoidal choroidal neovascular membrane, there's a branching vascular network which you can see with ICG and also with fluorescent. You can see it also with fluorescein angiography. But the OCT will show you the peaks, and you'll be able to treat it better with them. So in this case, of course, we all know what this is. This is central serous chorioretinopathy. And you can have the ink blot pattern, and you can have the smokestack. So here is the smokestack appearance that we do see. It starts from the dot, and it's very important in this condition to be there at the angiogram and see where the leakage is coming from. And I'll tell you why, the case I'm going to show us. And because you want to see that early stage to know where the leakage is coming from so that you'll be able to treat precisely. Now, this is a condition where a lot has been said about using medical treatment, but in my experience, medical treatment not as good. So if you see this is a patient who has a hyperfluorescent spot. So that hyperfluorescent spot, it's extrafoveal. It's extrafoveal. You can laser this. You can laser this. We've done lasers on this, and they've showed good outcomes. And this is why you have to be there, so that you can note the spot. Because if you see the patient, assuming you missed this stage, you will not be able to say the patient was having nausea, feeling very uncomfortable, you couldn't take photographs, because we said, remember that it's rapid sequence, is dynamic. So you don't want to miss the early stage. You want to get the early stage so that you know the spot at which the leakage is coming from. And this is because when you see them late, you can see the ink blot that has grown, but you don't know the exact spot where the leakage is coming from. So you missed it. So this CSR, and of course, this is a patient who has a dark choroid. So this is because the lipofuscin, and this is Stargardt's disease, the lipofuscin with all the deposits that you have there in the RP area blocks the fluoresceins that you should see. Remember what I said about fluorescein angiography. The fluorescein dye cannot, the light coming from the fluorescein dye cannot come through the RP. So now this is a patient who was referred, and this patient was diagnosed to have CSR. In fact, we treated this patient recently, and that's what he looked like. We put him on medical treatments to see if he was going to get better, but in fact, he got worse. It was better than this. The neurosensory retinal detachment that we can see there was better. So by the time he came, it was worse. And so we did a fluorescein angiography. This is 17 seconds. And you can see that 17 seconds, not much is seen. But by the time you go up to 60 seconds, roughly, you begin to see a spot. And this spot tells me that this is not his first episode, because you can see a spot here. You can see a hyperfluorescent spot. This is most likely a spot where the RP has dropped off. So this is like a window defect, but there's a spot that is increasing right there. Okay, so you take note of that spot and you are taking your photographs and you see that now that spot has increased. So that's like an ink blot. But this patient, so we decided to, though if you look at this, it seems as if it's so close to the fovea. But you notice that when the spot started, it wasn't really that close. And what you just need to do is to apply a gentle laser. At the time, this was recent, that we have, for some technical issues, the micropulse laser was not available to me. So I used the thermal laser. So it was just a thermal laser, the normal laser, 50 microns spot size. And so aim for that site. And there he goes. 1 week, just 1 week after the treatment. Okay? 1 week and he resolves. So it's to say that laser is very effective in treating many of these cases of CSR. And we're beginning to see quite a number of them coming to our clinics. CSR is a condition that's come. This is another patient. Yes, now this is a fundus photograph of the lady I showed you earlier. And this lady I showed you her fundus photograph, she was meant to have come here. This is her OCT. And she kept having recurrences of edema. Anytime she was not responding as well as we thought she should. And you can see this progression analysis on OCT. OCT is very valuable in managing these patients. And so we were wondering why. So I want you to take back, one important message I want to take back with you is that when you see a patient that is not responding to treatment as you expect, go back and reevaluate the patient. And fluorescein angiography, especially your retinal patients, fluorescein angiography is one of the things that can really be very revealing to you. And this patient and fluorescein angiography, we had to do our fluorescein angiography. Again, this is like the first case I just showed you of CSR. This is another case which we just managed recently. And you can see significant ischemia for this same woman. And on the fundus photograph, you would not have imagined that. So this is showing how fluorescein angiography can be used as a clinical, the clinical utility of fluorescein angiography in managing some of these patients. And so this patient, anti-VEGF alone is not going to be enough, or you just have to keep giving her anti-VEGFs. So she may need retinal laser photocoagulation because she has significant areas of hypoperfusion all the way around. Okay, so retinal laser can be augmented to save her eye. And besides, this is her only eye. Now, this is another patient, wide field angiography, seeing spots of light, floaters in the field of vision. And what we see is that sickle cell has hemorrhage on the retina. And he has received retinal laser photocoagulation from elsewhere before he arrived. And if you do his fluorescein angiography, you can see that this is very insufficient peripheral retinal laser, if you must agree with me. And that's a concept that we're seeing, insufficient laser. So the patient comes and say, oh, I've done retinal laser, but this laser is very insufficient, as we can see. And we must remember that the new vessels tend to grow in the border between the perfused and the non-perfused. That's where they grow. Okay, both for diabetic retinopathy, for sickle cell, they will grow at the border of perfused and non-perfused. So your retinal laser actually needs to cover this area. So fundus fluorescein angiography is very important for assessing. So this patient had already had laser, but we decided to repeat the fundus fluorescein angiography, and we discovered that this patient had insufficient laser. And now we can now know the area where we should start lasering this patient. Now, if you look, this is the same patient. If you look nasally, this patient has got areas of non-perfusion. So the question will be, should we laser these areas that are non-perfused nasally also, where there are no new vessels? Maybe we should, some schools of thought think that you should wait, you shouldn't laser them, but you should just laser areas where you have the angiograph. And this is another very interesting case, an only eye patient, a lady who had, she had angioid streaks with choroidal neovascular membrane right there that was exudating. Now I have to hurry up for the interest of time. This is yet a very interesting case. This is a patient also of mine who had melanocytoma, very large mass on his disc. You cannot see his disc, so this is the wide field imaging. but you can make out that he had some fluffy pattern on top of his disc. And these are new vessels on his disc, covered and masked by this melanocytoma. And you can see that there are areas here where there is non-perfusion. So we decided to do a fluorescein angiography. And you can see on the fluorescein angiography, we can see the new vessels are growing out from this, punching out from this. And we can see, though we say melanocytoma, some of them, the initial school of thought was that they were benign, but they're not that benign, as we know. And we can see that there's a large area of non-perfusion. So it has a branch retinal artery occlusion, which was responsible for these new vessels that he was having on the large melanocytoma, superior aspect of this large melanocytoma. So we did an intravitreal anti-VEGF, and we treated with retinal laser photocoagulation, and the vessels disappeared. He has responded well. We continue to follow him because with such a large size of melanocytoma, he may transform to malignancy, and at such a time, you may have to do an enucleation. So we see him now every year. So this is a patient, again, since it's just to show that some of these rare diseases are also seen in our environment, and we need to do angiogram for this. This is a patient who has serpiginous choroiditis, and this is a patient who, this is a disease that is actually that I feel we should be seeing more of, because this disease is akin to tuberculosis, and so we have tuberculosis in our environment. And so you can see that there's hemorrhage in the center of his macula. This eye is scarred. He came in with his mother. He's just 14 years old, and this is fellow eye. Fluorescein angiography is fellow eye, and we can see the typical placoid pattern extending to the disc. We treated him with steroids, high-dose steroids, and he did very well. In fact, he regained up to 6/12 vision in his left eye. The right eye didn't do as well because this eye had already presented it. So what are the hazards of fluorescein angiography? I have to hurry up because my time is almost spent. So there are some unavoidable hazards, including the red after image you see from the photo flash, temporary tan skin color, discoloration of the urine. And you must warn your patients about this. Tell them that otherwise they could call you back and say, doctor, my urine is not the right color. Tell them they'll be orange, yellow, it will last for some time. They should be encouraged to take a lot of water. Some of the patients, if they go to somewhere where there's blue light, they've had fluorescein angiography, and maybe they go to a party and there's blue light, you notice that their body is going to fluoresce because of the temporal tan that they have. Remember that these patients who have fluorescein angiography, they cannot do fluorescein serum, they cannot do a fluorescein test, fluorescein-based chemical test for some time. Some people argue that they shouldn't do it for 24 hours because it might alter the results of the test. So there are more serious side effects, including the transient nausea. In my experience, a lot of the patients will have nausea and vomiting, the hives, dyspnea. We always leave the cannula in place. If a patient has urticaria or rashes, he may have something worse. Now, I will not do fluorescein angiography, except it's really, really, really important on a patient who has asthma. So because we don't want to trigger it. So there are more serious adverse events like tachycardia, anaphylactic reaction, myocardial infarction, respiratory or cardiac arrest. I must be honest with you. In more than 15 to 20 years that I've had experience with doing fluorescein angiography, I've never come across any of these very severe reactions. But maybe also because we're very prudent in our department. If you have any contraindication, we keep away. So one of the things we usually do your serum electrolytes because of the diabetic patients that we see who may have renal impairment. Once there is a renal impairment, we don't go ahead with serum with fluorescein angiography. Now, I'll quickly move over to OCT angiography, and there's a lot to discuss. I must say that these topics of angiography, there are a lot to be discussed within a short time. And I'll try to do some bit of justice to this. But this is really a topic that is important because it is now and the future. The future is OCT angiography. Why is it important? It's important because we need to, because of the hazards of fluorescein angiography, the presumed hazards, and the fact that it's so convenient. It's so convenient to be able to see the blood flow within a short period of time. We need to understand the basic principles of Octa, Roche rationale for Octa, and we need to be able to differentiate it from the other modalities of angiography. So I'll have to hurry up now. Right, so I think my time is going fast. So how much more time do I have, please? How much more time do I have, Martha?
So you round up about 10 minutes. We've added some time because you've not yet. So maybe about 10 minutes.
Okay, so I will have to go quickly over the principles of Octa. So the important thing about Octa is to realize Time is never our friend, but you need to know this. The basic thing about Octa, OCT angiography is the speed. The newer OCT machines have the speed. So the Fourier domain OCT, the swept source, they have faster scanning speed. So they can scan and give you three-dimensional images. Because you have three-dimensional images, you can segment them. Now, segmentation is such a very important topic. But the scanning of the OCT machine, the A scan that it produces can scan a particular spot several times. So let's pick a spot where there's a blood vessel. Okay? Now there's a blood vessel and there are red blood cells moving through that blood vessel. And you scan that same spot several times. Within that area, you will have static. Remember that the OCT has to do with interference. So there are rays that go in there. There are rays that go in, they scan that spot, they come back, it registers, and then another goes in. As it's scanning, the red blood cell is passing by. So you have the motion by the red blood cells, which is giving you a feedback. But around it, you have things like the blood vessel, the interstitial, which doesn't move. And so you're also getting a scan from the structures that are not moving. So the difference between the structures that are stable and the structure and the red blood cell that is moving, that is what the OCT angiography is based on, okay? So it's motion contrast. It gives you a motion contrast signal. The red blood cells are moving, so you're getting something, feedback from them, okay? And at that spot. And there are things that are not moving, including the blood vessels, retinal cells, they're not moving, so you're getting a feedback. The difference between them is the motion contrast that we talk about. So in terms of the principle, I will have to draw up. The moving particles can be differentiated from the static tissue. So this is summarizing the basic principle of OCT angiography. And then I'll have to go through the remaining slides. I think doing this kind of topic in 1 hour is just like a child's play. It's not possible. You can't cover ICG, fundus fluorescein angiography, and OCT angiography all in one. So we can just touch on different things, okay? So the moving particles can be differentiated from the static tissue by the repeated scan, just like I've said. And the changes of the OCT signal in subsequent scan is caused by the moving particles, and that gives you the angiographic contrast. The A scans scan in a range of up to 70 to 100,000 scans per second. So you imagine every second. Think about it. Just imagine, it's mind-blowing. And now we have scans that can do 400,000. No, we're not talking about 100,000 anymore. 400,000. So they can give you, so you see, in the initial Octa that we had could give 3 by 3, 6 by 3, 6 by 6, 12 by 12. Now we're talking about wide field OCT angiography. Okay, so these are that's the future. You'll be able to see. Initially, we were saying OCT angiography, you can just image a small area, but now the talk is about wide field OCT angiography. So the other principle that you need to know about is about image segmentation. Image segmentation is about partitioning. So you have digital images and then you segment them. So look at this. Let's say this is a cube. So this is what you get from the OCT. You have a cube. And so the machine is able to break down that cube into different layers. That's segmentation. And segmentation is becoming so important in the world because when you are talking about artificial intelligence, talking about automated machines, screening, you're talking about using segmentation models. You want to segment the area of the lesion. Say you are looking at fluid, maybe it's an OCT. So you want to segment the area where you have the fluid. So that area you have the fluid, you want to devise mechanisms by which you can segment them, quantify them. And it's so possible that you can quantify a lot. We as human beings, for us to do that, it takes us lots of time. But if the machine can do this, they can do this very quickly. And so you can actually prognosticate. You can do a lot with the data that you can get from segmentation, okay? The other concept that we have is the en-face imaging. En-face, so this is an en-face image. You have, en-face means when you're looking direct, it's a French word. When you're looking directly at the image. So you see the cross-sectional, this is a patient of mine who has pigment epithelar detachment from polypoidal, he has polypoidal choroidal vasculopathy, and that's the polypoidal area of the polypoidal lesion. And we can see the pigment epithelial detachment that he has. And so we can follow him. This patient has received several anti-VEGF and even has gone to the level of also getting Visudine laser into his eye. So there's a lot to say about the technology, comparing FA versus OCT. FA only images the superficial network, whereas OCTA can image both superficial and the deep. And I use this to compare. This is a patient that I showed you earlier of mine who has central retinal artery occlusion with macular infarction. And when I compare, so you did his fluorescein angiography and then did do the OCT angiography, you can see it compares the superficial capillary plexus by the fluorescein angio and the OCTA is similar. There's another very important aspect of the OCT angiography. It can image the peripapillary vascular network, which the fluorescein angiography cannot do. Okay, so the OCT angiography is able to see distinct, is able to maintain distinct images. For instance, here, this is a patient who has diabetic retinopathy, and you can see new vessels forming here. He has significant ischemia. Now, if this was fluorescein angiography, you wouldn't be able to see this because there will be so much dye leakage around, so everything is blurred. You wouldn't be able to see much, okay? Biomarkers. So this is an article we did looking at the OCT metrics and biomarkers. And one of the areas that we focus our attention on is the FAS, the foveal avascular zone, measuring it, looking at the area, the perimeter. So in this paper, we were able to show that in those we compared patients who had sickle cell grades stage 3 and 4 with normals. And we were able to show that in both the deep and the superficial capillary network, they had reduction compared to normals. And we're also able to characterize the 4 types of FAS that you can have. This is a regular pattern shown on both the superficial and the deep, which you tend to see more in the patients who have sickle cell retinopathy. This is the normal type, the round configuration. This is the oval, oval type, okay? And then in this configuration, you see, so this is the kind of configuration you see. And this is another patient, you can see how his FAS is looking, very irregular, both in the superficial and the deep. So we will not be able to talk about the artifacts, but artifacts is a big issue. Here we see uses of the OCT angiography, diabetic retinopathy. As I've said, you'll be able to see the areas that are vascular, areas that are not perfused. A lot to say about this. This patient has got macular edema, and you can see the ad exudates there. Still diabetic. I'll just go quickly to this OCT. I found OCT angiography to be so useful in monitoring patients who get anti-VEGF. And this is a patient who was an Avastin, he wasn't doing so well. And we had to change to Eylea. And he responded favorably to Eylea. And we can use OCT angiography to monitor. And this is a patient who has angioid streaks. And here we can see the choroidal neovascular membrane. When you look at choroidal neovascular membrane in this patient, you're looking at the outer part of the retina, okay? This patient has got branch vein occlusion, inferior vein occlusion, peripapillary vascular loops. This is a rare condition which we have. This is a patient of mine as well. Now, this is a patient, young girl who woke up with sudden loss of vision, 15-year-old. And you can guess what this is. This is papillophlebitis. It's just to say that some of these lesions we think we don't have in our environment, we really do have them. She received anti-VEGF and she's done well. We fold her up and she's done well. That's her. And we use OCT angiography to image her. And we can see that she's improved a lot over the years. This was after the first Avastin, second Avastin, and that's how she looks. We've also used OCT angiography to monitor surgical outcomes. And this is a patient who has an autologous retinal transplant. And we use OCT angiography here to show vascularization. We show that the graft that were implanted actually can get vascularized. And this is very important. Peripapillary vascular network. This is glaucoma week, so I must say something about glaucoma. And so this is a patient who has a normal peripapillary vascular density. And this is one of the things we use when we're trying to know if this is really glaucoma. You can do the OCT angiography of the disc, and you'll be able to say whether this is glaucoma or not. So I want to invite you all to come to our OCT course, which holds at all the OSN. These are past ones we've had, and it will be a pleasure for you to join us at the coming OSN in Kano State. Thank you very much.
Thank you very much.
Yeah.
Thank you very much, sir, for this excellent presentation. Please, we would like to receive questions and comments. We've had a few comments on the chat box. Please, you can send in yours if you've not done that already. So, sir, I'll just ask a few questions that have been raised. The first one says, how frequent do you use FFA or ICG angiogram in your practice? Since even it says, since even in one study, the need for FFA had dropped very fast since Octa.
Well, I don't think, well, I wasn't allowed to, well, the time didn't allow us to do that, but I don't understand the basis of the question, because FFA is still a very important tool, and that's why we're discussing it here. And that's the reason why I spent time to show you some of the cases. Octa will not show leakage. So patients who need to examine Octa, and besides that, I didn't have time to discuss this because this is a very important point. Octa has its place, and some of the good things about Octa is that you can repeat it. So patients come, you can repeat Octa every week. But Octa cannot replace FFA because FFA still sees wide periphery. Like I showed you some of the lesions, if you paid attention during the discourse. You cannot see C-fans with Octa, okay? C-fans, right now, we are in the future. We are living in the future as it is. And that's because we are dreaming of having wide field Octa available. But even wide field Octa is limited because Octa does not show leakage. Okay, that's one big thing about Octa. It doesn't show leakage. And FFA will still show you things. For instance, I showed you a patient who had CSR, who we managed, and to show you this leaking point. So, and the question about how often we do it in our department, we still do FFA. Even today, we had to do FFA in the sickle cell patients, even before this presentation. So FFA is still a very important, and that's the idea of this presentation, to say that FFA is still very much alive, and you should be doing FFA in your department to assess your patients thoroughly. What most departments worldwide will do is that for these patients who come first time to characterize the lesions, they will do the FFA at the first visit. And then if the patient is not responding, like I said, as I alluded to, then they will repeat the FFA after some time, not responding, because they want to then reevaluate and say, are we on the right track? And I did show that also. Some patients who had laser previously for sickle cell, you can still see them having hemorrhage. You repeat the FFA and you see that the laser is not sufficient. So we still do, the answer to your question directly is that we still do a lot of FFA in my department. At least even this year, we've done, we would have done, this year alone would have done maybe close to 100, yes. So your patients who have diabetes, your patients who have retinal vein occlusion, you should do FFA on them. Because there are certain things that Octa will not give you. And the Octa we have available in our environment. Most of the time, like in our department, we have the 12 by 12. But you know, there are much more lesions outside the 12 millimeter area where the Octa covers. Okay, any other questions?
Thank you, sir. The second question says, if you need retinal angiogram, FFA or ICG for both eyes, can we do it in the same session or on an interval?
That's a very important question. So some machines, like the Merante, there are some machines that can do both. And indeed, the digital, many of the digital, the newer end, high-end machines have facility to be able to do both ICG, so they dilute both the ICG and the fluorescein angiography in one and inject it at the same time. And you can do both the ICG and the fluorescein angiography in one sitting. You don't need to inject one and then wait and do another. No, you mix the ICG in fluorescein angio, okay? And then you inject it once. But of course, you would have made sure that your patient doesn't react to any of the dyes. And then you take your images. You do your rapid sequence images, and you can do both ICG and fluorescein angiography at the same time. Now, the machine we have the Claros. So the Claros is a newer machine, newer version. So the ICG component of our machine is not yet available. So we're hoping that by the end of this year, we would have the software installed in our machine, and then we'll be able to do more ICGs. There are patients, for instance, your patients who have polypoidal choroidal vasculopathy who need to be imaged, and we do see choroidal vasculopathy in our country. Mind you, I think it's a very important differential diagnosis. When you see those younger patients with hemorrhage, it is quite true that to see the polyp, like I showed, OCT, you can image directly through the OCT, using OCT, image directly through the polyp and be able to classify it. Okay, but ICG plays a crucial role in being able to prognosticate, being able to define where the borders are so that you can treat more accurately. It's all about patient outcomes and improving patient outcomes. So you want to make a good diagnosis, want to delineate. In the past, now I'll tell you a little bit of history. I still remember that then because that was the early years of my residence. During the macular photocoagulation study, the MPS, then they were using fluorescein angiography to delineate to define, if you remember the MPS, to define the borders. That was the study that really showed the value of photocoagulation for treating choroidal neovascular membranes. But then they realized that there were membranes that were hidden. That was why the definition of occult came. The definition, occult membranes, pigment epithelial detachment, hotspots, late leakage of undetermined cause. And it was ICG that helped to define these occult membranes. The occult membranes are the membranes that are under the RP. The fluorescein angiography will not be able to see them. Why? Because I've also mentioned during the presentation that the spectrum of light that emits from the fluorescent, from the fluorescein dye, it's the same spectrum of the RP. So the RP is going to block it. So it can't come out. All right. That's why you need a longer length wavelength. And that's what ICG provides for you. The ICG will emit around 830, 850, and maybe even up to 900 in some filters. Okay. So if that is able to come through, then you'll be able to see the image classically as it's supposed to be, and then define the borders. Because in those days of imaging of the macular photocoagulation study, you wanted to laser the borders. You will laser the border, then you fill in. So you wanted to see the defined borders. Okay, it's true now that these days we don't do much. I hardly ever do photocoagulation for choroidal neovascular membranes because the anti-VEGFs are there, and the anti-VEGFs do well. They work very well. So the need to define those borders are not as important as now. But if you're going to be doing things like PDT, lasers, which I think we should still be doing and promoting in our environment, like I showed you a case of CSR, and that case did very well, and that's not the only patient, and I'm not the only one saying this. So if you're able to spot, and I think that there is more CSR. We are seeing more CSR than we are seeing before. CSR belongs to the spectrum of pachychoroid. So if you're able to do a good fluorescein angiography, note the timing of the hyperfluorescent, note the spot, then you can place, and even the ordinary laser, that's the point. The ordinary laser, I didn't use the subthreshold laser, the micropulse laser. It was just the normal laser that you use in your clinics. But reduce the spot size to 50 micron spot size, okay? And then use longer duration spots, longer duration energy, but very low low energy. So longer duration, very low thermal energy. So you don't even want to see a blanch. You don't want to see a blanch. We don't want to see a blanch. So we're planning a study, a multi-center study on this. And so if anyone who's interested on CSR, lasers for CSR, we just want to show that yes, lasers can be done, even in very difficult cases, even those cases that are still close to you don't want to laser inside the foveal vascular zone, no. But if it's like some microns away from the foveal vascular zone, like maybe 100, 200, 300 microns away from the foveal vascular zone, you can apply gentle laser to these lesions and they will do very well. Thank you.
Thank you very much, sir. There's a comment here. Sir, can we have another session on the OCTA? It was rushed. I appreciate that.
It's my delight to do that. But it's my delight to do that, but I don't think it's up to me. It will be my delight to do that, but it's not up to me. It's up to the executives who I'm under and who ask me. But I think the OCTA is very. I will subscribe to that too, maybe at some other point. Or I will also encourage you to come to the OSN in Kano. We're going to now have a 2-day. We've been having a 1-day meeting. It's going to be 2 days. So register for the pre-congress. It's going to be 2 days so that we have enough time for the OCT angiography, because there's a lot to say when it comes to OCT angiography. It's the present and the future. One of the things that OCT angiography will help us do is that with the aid of OCT angiography, we'll be able to cannulate blood vessels, okay? So you can do, already it's happening, where you have intraoperative OCT. So if you imagine that we have intraoperative OCT, and with intraoperative OCT, OCTA, intraoperative OCT, we have intraoperative OCT, but we're going to be having intraoperative OCT angiography, okay? Now, with intraoperative OCT angiography, and if with incorporation of adaptive optics, you're going to have high resolution images. So with such high resolution image, you'll be able to cannulate blood vessels with micro, very small cannulas so that you can dislodge emboli, whether it's fibrinoplatelets, you can thrombolize them, you can do thrombolysis, or it's calcific, or so you're going to see so much more happening in the future. It's all about imaging, the quality of images that you're able to get. So I think it's a very good, I'll be happy to do, so if just a session, I think it's very ambitious to do fundus fluorescein angiography, indocyanine. If I had done details of fluorescein angiography, I think that won't take up all the time. But I think it's up to the executive to decide. Any more comments? Matt, are you there? Or am I the one who is lost?
Okay, you're not lost. I don't know if we've lost Dr. Martha Mary, but thank you, Dr. Okonkwo, for a very, very brilliant presentation. Quite enlightening. I think we've exhausted the questions for now. I don't know if anybody has any comments. Do we have any comments? And we can still take more questions if there is any. Okay, Dr. Akariwe has her hand up. I'm going to unmute her.
Okay.
So that she
I'll
can
be very
ask
happy
her
to
question.
I'll be happy to take more questions. Okay, I think Dr. Mata is is trying to come back in.
Yeah, she's the host, so she'll have to unmute Dr. Akariwe. Professor Faber, are you on?
Yes, I'm on.
Please, can you unmute Professor Akariwe to ask her question?
Okay.
Your co-host. Thank you.
I'm not sure I can unmute her.
Yeah, you've unmuted me.
Okay, I have. Okay,
You've
good.
done that. Yeah. Okay. Thank you very much.
Thank you.
Thank you very much, Dr. Okonkwo. That was a highly stimulating lecture. And thank you, Vitreoretinal Society of Nigeria, where you have really kept us engaged. You can see from the attendance, the number of participants, that each of your sessions are quite sought out. You know, it's just to say thank you for putting this together. We really appreciate it, increasing the body of knowledge among our colleagues. Thank you very much.
Thank you, Prof.
Dr. Wilson has his hand up. Dr. Achibu, can he speak? Dr. Wilson.
Thank you very much. I don't know whether you can hear me now. Can you hear me?
I can hear you, dear Wilson.
Yes,
Okay,
we can.
thank you very much, Dr. Okonkwo. As always, your presentations your presentation was very stimulating. Although the initial comment I made, you almost took it away from my mouth when you mentioned the pre-conference course at Kano. But I was going to suggest that, like we used to do in the early days, whether we shouldn't consider a whole day course on the 3 angiographies. I know we did things like that those days for intravitreal, even OCT and fluorescein angiography. Those days we used to come to Lagos for that whole day course.
Yeah.
It was quite
Yes.
beneficial. Those were some of the things that stimulated me into going into Vitreoretinal. I was wondering, we are fast evolving. Ophthalmic practice is fast evolving. Even Vitreoretinal practices is even evolving even faster. So I think that it, as a form of updates or refresher, we should consider having a whole day or even 2-day course, physical attendance, where we should discuss some of these things. They have a way of affecting our practice. I was just thinking about it, if the VSRN can consider something like that, and we come together and discuss some of these things. It can make a lot of difference. Thank you once again for your nice presentation.
So, Dr. Wilson, thank you so much. So, at the last meeting we had, and Martha was there, okay, so Martha is saying that we need to unmute her. So maybe we can unmute her since she's the moderator. So at the last meeting, we decided that one day we had a very extensive time discussing the OCT. And we decided that one day, the same thing, what has just played out here happened also, because OCT and geography could not be finished. So we decided that we would have 2 days and devote one whole day to OCT and geography. And I think it makes a lot of sense to me, because these are modalities of imaging that we now use so frequently in retina, in glaucoma, and in anterior segment. Even in anterior segment, if you come for the course, we've had them, the courses now, we had it in Lagos, we had it in Benin, we had it in Enugu, and we're planning the Kano course as well. So if you came for that, you see that there is a desire for people to, I mean, there's a desire for this, there's a desire for more understanding, like you said, refresher. So maybe the VRSN should look at this so that it can be on a wider scale, and we can incorporate into what we're already doing. So that in Kano, we can have a much bigger audience, and maybe 2 days instead of just 1 day. So the executive of the VRSN, so please.
Okay. Thank you very much. Thank you, Dr. Okonkwo, for this fantastic presentation. I want to thank everybody who stayed by and all the comments. Sorry, I missed some. I think the internet took me out for a while, but it's just like the comments you've made now. Many people have mentioned that we need more time. So we invite you to the course in Kanu, and as well, the VRSN ESCO will decide on what next to do. So over to the VRSN chairman or representative. Thank you.
Thank you very much, Dr. Martha Mary Udoh, for being a wonderful moderator. Can you hear me?
Yes, ma'am.
Yes, thank you for being a very, very wonderful moderator. And thank you once again, Dr. Okonkwo. This was a masterclass presentation, and you are rushing through it all, and we actually need more time. That was the reason why we separated the 2 presentations, the OCT last 2 weeks and the Angiographies this week. And we've heard all the comments and suggestions. And in keeping with our theme for the year in VRSN, we're actually looking at imaging and diagnostics in retina as our theme for the year. The aim is to build the foundations of retinal practice. So we're going to go back to the scientific committee and the VRSN ESCO and look at how we can expand on this, probably getting another session. But this is actually an opportunity for people to attend the OSN, because that is one place that you're not just going to hear it online virtually, you're going to be physically present and you get to see these patients and also do some hands-on. So we're inviting you to OSN and to the VRSN corner in Kano for more education and enlightenment on OCTs, OCT angios, and the foundations of retinal practice. Thank you once again, everyone, for attending. We appreciate you and appreciate the time you have spent with us. It was meant to be 1 hour, but we've stretched it to 1 hour, 30 minutes already. So I don't know if the chairman is around, but if he's not, I think he's currently not around. So it's goodbye from the Vitreoretinal Society of Nigeria. Do have a pleasant night. Thank you for coming.
Thank you. Good night, everybody. Have a pleasant night rest.